one era was there when nobody was attending a delivery. Now, a neonatologist or a pediatrician or a well-trained person is available in the in the delivery room. So the scenario has changed a lot. And the thing is, like initially the standardization or protocolization of the delivery room practices was not there. Now it is there with the NRP programs and all. अभी मैं डॉक्टर लड़के सर से बात कर रहा था तो बता रहे थे कि हम लोग काम थी किसी के स्कूटर पे बैठ के जाते थे वहाँ पे डिलीवरी कॉल्स अटेंड करते थे मैं और अनिल ऐसे ही बात करते तो बोलते कि हम लोग रात को जब डिलीवरी कॉल्स अटेंड करने जाते थे तो डॉग्स यूज्ड टू रन बिहाइंड अस तो फिर ऐसा लगता था कि अरे क्या है अपनी जिंदगी कैसे चले ऐसे तो देन वन फाइन डे अनिल बोले कि आजकल कुत्ते दौड़ नहीं रहे मैं सोच रहा हूँ कि गरीब बेचारा पीडियाट्रिशियन है कहाँ भागते हैं इसके पीछे so there has been change. Now people reach with ambulances, with incubators, transport incubators for the deliveries. So I'll be talking on the changing scenario of delivery room care in preterm and term babies. So why do we need to change? So considering the causes of neonatal death in India, there are almost 50% would contribute like intrapartum and preterm deaths contribute almost more than 50% to the deaths in the initial period and in between 7 to 27 days the preterm, intrapartum and the sepsis adds on to it. So we need to target this section. So as Indians, where are we? So we contribute to 25 million births per year to the world, which accounts to almost 20% of global births. Almost 0.9 million of these die in neonatal period, which accounts to almost 25% of global deaths. So India accounts for highest births and neonatal deaths globally. If you consider the state-wise NMR rates, only three states, Kerala, Delhi and Tamil Nadu have achieved NMRs according to our SDG goals by 2030. We are now targeting almost around 8 states have been targeted so that we will be able to achieve our NMRs. Still we are going to lag behind. So with current trends, India is unlikely to achieve SDG 2030 NMR targets of 12 or either of NHP 2025 targets. So to provide adequate care, at present India needs 20,000 to 30,000 level 3 neonatal intensive care units, care unit beds, 75,000 to 1 lakh level 2 special NICU beds, and the number of beds available, especially level 3 NICU beds, are grossly inadequate. So to reach this SDG 2030 targets, individually 430 districts of NMR which need a higher rate of improvement than they had up to 2017. Simply knowing the cause is not enough. So structural deficiencies are there and we need to address to that. So as per National Family Health Survey 4, the percentage of institutional births have doubled from 38% to almost 80%. However, the increase in coverage has not translated in commensurate reduction in maternal and neonatal mortality. One of the major factors being inadequacies in the quality of care provided in the health facilities. So how do we change the situation? So we need to change our strategy so that we will be achieving our targets. So if we consider what interventions would help the most, so in the descending order of impact on neonatal mortality, so first would be care during labor and childbirth. So we need to target our delivery rooms. Then the care of small and sick newborn, care of healthy newborns and immediate newborn care and preconception and antenatal care. So number one would be care during labor and childbirth. So Government of India has got various plans. So Lakshya is one of the good initiative which is targeting the labor room and maternity OT in improving quality of care for mothers and newborn during intrapartum and immediate postpartum period. It has been launched by Ministry of Health, Government of India. The program is based on point of care quality improvement methodology, the simple 4-step process, and has been used in the improvement of patient care process. So quality of care is increasingly recognized as a critical aspect of the unfinished maternal and newborn health agenda, mainly with respect to care around birth and in the immediate postnatal period. So quality of care, there are various factors like safe delivery should be there. The whatever measures we are taking should be effective, should be timely, they should be efficient and equitable, or should be reproducible every time. Then the measures should be people-centered. So standard one, if we look at the, as I said, the first one, we need to take care of the labor room or the deliveries initially. So the quality statement would be newborns receive routine care immediately after birth. Newborns who are not breathing spontaneously received appropriate stimulation and resuscitation with a bag and mask within 1 minute of birth as per standard guidelines. Newborns receive routine postnatal care. Preterm and small babies receive appropriate care. Newborns with suspected infection or risk factors for infection are promptly given antibiotic treatment. So considering that newborns receive routine care immediately after birth. So immediate drying followed by skin to skin contact prevents hypothermia, promotes physiological stability, increases colonization with protective familial bacteria, facilitates early initiation of breastfeeding within 1 hour. Delayed cord clamping decreases anemia in neonates and prevents brain hemorrhage. Breastfeeding within first hour has been shown to have an inverse relationship with breastfeeding difficulties and neonatal mortality. Translation of these evidence-based interventions into effective clinical practice is a challenge in the public healthcare system, especially in low resources setting. So immediate drying of after birth. So the emphasis was on the thermoregulation. So now the NRP says that you need to have 2 sheets which are sterile, which has to be pre-warm prior to delivery. हम लोग जब इनिशियली जाते थे तो जो भी एक साड़ी है, जो भी है, जो मिला कपड़ा वो दे दिया जाता था, वो स्टराइल रहता था। और हमारे यहाँ एक कौन सी प्रथा है कि पुराना कपड़ा चाहिए, नया कपड़ा नहीं चाहिए। लेकिन पुराना चाहिए ठीक है, धोया तो ठीक है ना। तो एक बार मैंने ऐसे बेबी को हाथ में लिया तो मुझे कुछ ऐसे कड़क कड़क लग रहा था। तो फिर मैंने वो उसकी ग्रैंडमदर को पूछा ये क्या है, इसमें क्या है। अरे वो कपड़े तो पापड़ सूप बोले थे, अक्टूबर के कपड़ा। तो ऐसे भी कपड़े मिल जाते थे जब we used to take babies in this thing. So now the thing is like that you need to have 2 pre-warm, 2 sterile sheets. Then discard wet linen immediately after initial drying. Keep radiant warmer on 20 minutes prior to delivery. Then keep your room draught free. In case resuscitation is needed, resuscitate under warmer. So these were initiatives taken for thermoregulation of the baby. Then delayed cord clamping. The NRP says more than 1 to 3 minutes is basic NRP and 30 to 60 seconds is advanced NRP says. But currently 1 minute or plus is the timing which is considered for delayed cord clamping. So for 1 to 3 minutes, then in preterm it stabilizes hemodynamics early, need fewer blood transfusions and improves survival. In term and late preterms, it has shown better hemodynamic parameters and neurodevelopmental outcomes. It is not indicated in case there is placental separation, that is AH or any placental issues are there. In case of multiple gestation, studies are going on, but yet it has not been recommended. And newborns were born non-vigorous. You have to immediately cut the cord and take the baby to resuscitation area. Then, if the baby has cried and You have cut the cord after delayed cord clamping. Then you have to put the baby directly to skin contact. So there are so many benefits which I already mentioned. Then breastfeeding before 1 hour. Initiate breastfeeding before 1 hour. I think Rawat sir is there, and as a student, I learned so many things from Rawat sir about breastfeeding. Like he has been advocate since of breastfeeding since then. So breastfeeding to be initiated before 1 hour of delivery. Nowadays, there is a teamwork. Now we have lactation management also. This topic is I have taken recently. This is Dr. Surbhi Govardhan. This is lactational management consultant, and during one of the seasons, like if once the baby was immediately delivered, crawl was attempted, and baby was immediately put to the breast, and feeding was started. So we have to have a team approach to achieve our goals. Then there are a few other newer recommendations in the delivery room, like anticipation and preparedness. So anticipate if the delivery and transition of the baby is going to be complicated. So in that case, if you feel that there is going to be some complication, accordingly you be prepared personal wise as well as equipment wise. Ask the obstetrician these questions. These are the NRP questions, like what is the gestational age of the baby? Is amniotic fluid clear? And any additional risk factors like antepartum, partum, or intrapartum or postpartum. Then umbilical cord management. So you discuss these four things with the gynecologist. ये थ्योरी के लिए ठीक है, बट मुझे मेरे सीनियर ने बताया था कि जब भी कॉल को जाओगे तो गायनेकोलॉजिस्ट को कोई सवाल नहीं पूछना है, तो दूसरे आगे बोलेंगे नहीं. फिर मैंने ऐसे एक बार पूछा कि मैडम सीजर का इंडिकेशन क्या है, तो अगली बार से कॉल बंद हो गया. मैंने बोला ठीक है. तो कीप योर माउथ शट टिल द टाइम यू वांट टू वर्क. ये फंडा अभी मैं यूज करता हूँ. तो बी प्रिपेयर्ड फॉर neonatal transport as well. Then routine suction of the airway. ये एक बड़ा कंट्रोवर्शियल और ये रहता था इनिशियली. सिस्टर्स या दोज यू यूज्ड टू अटेंड डिलीवरीज, तो वहां पे उनको लगता है कि सक्शन करके जितना हम फ्लूइड निकालेंगे उतना बेबी अच्छे से क्लियर होगा, उसका एयरवे क्लियर होगा, बेबी अच्छे से क्राई करेगा. So nowadays the recommendation is that it is not indicated for a crying and vigorous baby. It is not at all indicated. Don't do suction, oral or nasal suction. Clear secretions if baby is not crying or has a poor tone, or if the secretions are obstructing the airway, or before starting positive pressure ventilation. ये रिसेंटली पिक निकाला हुआ है चंबू का. ये चंबू लास्ट 3 साल से वो नर्सिंग होम में यूज हो रहे हैं, बट अभी उसका इलेक्ट्रिसिटी गया, सेल्फ इन्फ्लेटिंग फीचर्स गया, सब गया. तो ये एपी को हमेशा वही लाके देते हैं, अभी भी ऑटोक्लेव नहीं करते. तो मैं बोला अभी सक्शन की जरूरत ही नहीं, आपको चंबू बाजू रखो. तो these are the things still happening. Then stimulation. Stimulation is like gentle, handle with care. Babies are too gentle, so handle them with care. Gentle rubbing of back, trunk and extremities is good enough. Overly vigorous stimulation is not helpful and can cause injury. So as you must be regularly saying that if the baby is not crying, they start chest compression immediately. उनके हाथ में बेबी रहता है तो तेज दवा चालू करते हैं. फिर अपने तो their way of their perception or their way of giving stimulation is quite different than the one which is recommended. सक्शन के एक किस्सा याद आता है मेरे को. एक बार कॉल आया था मैडम का कि सर हम सक्शन कर रहे थे बेबी का और वो रेड रबर कैथेटर चले गया बोले पेट के अंदर. ऐसे तो नहीं होगा क्योंकि हम लोग डालते हैं तो भी निकलता है बाहर, तो कैसे क्या अंदर गया. तो मैं आता हूँ नहीं, बोले मैं उंगली डाल के देख रही हूँ तो कुछ लग रहा है. बोला बोले उसको खींचो मत, आप उसको कुछ मत करो, शायद लैरिंग्स हो सकता है. तो फिर नहीं ठीक है आप आ जाओ, मैं कुछ मतलब बेबी रो रहा है ना, ठीक है ना, तो आप कुछ मत करो. देन आई रीच देयर. तो मैं बोला कि नहीं मैडम वो तो नहीं है. तो देन शी सेड नहीं, एवरीवन वाज वेरी श्योर, द स्टाफ नर्स, द ऑब्स्टेट्रिशियन, दैट वो अंदर ही गया. Then we took the baby for X-ray. X-ray निकाला तो X-ray में दिख नहीं रहा था. तो X-ray में रेड रबर कहते थे दिखता है कि नहीं, इस पे एक सवाल निकला. तो फिर से उसका X-ray निकाला अलोन, तो वो भी है. फिर वापस आए हम लोग, तो मैडम बोले कहीं ना कहीं तो गया होगा. तो अब बॉटल में भी नहीं है, बेबी के पेट में भी नहीं है, तो मुझे कहीं ना कहीं ढूंढना. तो मैं ग्रीन कलर की ट्यूब आती थी जो सक्शन के लिए यूज होती थी, तो ये काट के देखता हूँ. तो ये नहीं यार, अभी वो एक ही ट्यूब है, मैं काटू मत उसको. बोला नहीं, अभी इतना 2 घंटा मेहनत किया हूँ, अभी उसको देखना ही है मुझे कहाँ है वो, कहते थे. Then I cut the tube and the tube was inside the green tube. So this kind of high pressure of suction means it is harmful to baby also, or such kind of thing can happen. So एक बार मैं कहने के वो बोलते थे कि आप अच्छे से रुलाते नहीं हो और अच्छे से सक्शन नहीं करते हो करके बेबी को टीटीएन होता है, फिर आप शिफ्ट करते हो बेबी को. मैडम नहीं, ऐसा नहीं है, कुछ देयर आर सम डिफरेंट रीजन, but they are the same concept. Then use of oxygen. Oxygen is a medicine, it's a drug. So we need to use it judiciously. Hyperoxygenation can be injurious, and we need to monitor with pulse oximeter. So now everyone knows that there are target oxygen saturations, and initial oxygen concentration for positive pressure ventilation for a term baby it is room air, and for less than 35 weeks you can use 21 to 30% of FiO2. Then in between there was like recommendation, a great recommendation that every baby with meconium strain lacquer tracheal suction karna hi hai. But now the things are clear, and the 8th edition of NRP says that whenever there is meconium strain amniotic fluid, you have to anticipate the need for resuscitation. Routine laryngoscopy with or without tracheal suction to prevent meconium aspiration is not recommended in all babies. Intubation tracheal suction may be necessary if positive pressure ventilation does not inflate the lung and airway obstruction is suspected. For a vigorous baby, routine care is recommended. Then coming to needs for preterm, हमारे एक सिस्टर थी, बोलते थे सर एक प्रीतम आया है, प्रीतम आया है. तो हमको लगा प्रीतम प्रीतम क्या है. तो then when we started managing preterms, we could see that they are really more tough than preterms. हमारी प्रीतम तो भी एक बार मान जाएगी, मानते ही नहीं कभी कभी. उनको कितना भी प्यार दो, कितना भी केयर दो, फिर भी कभी ना कभी गड़बड़ करते रहते, हमेशा रंग बदलते रहते. तो they are actually preterms more than preterms for us. Then when you are researching a preterm, the risk factors associated, there are risk factors associated with premature birth. Then additional resources are needed: temperature maintenance, oxygen management, assisting ventilation, decreasing birth injury are the matter of concern. Special precautions after resuscitation are also there. So additional risk because they have excessive heat loss, vulnerability to hyperoxic injury, they have immature lung and diminished respiratory drive, vulnerability to infection, immature brains that are prone to bleeding, and small blood volume. Additional resources in the delivery room are needed, like more than one person is needed. Additional strategies for temperature control are needed. Additional equipment wise, we need compressed air, we need oxygen blender and pulse oximeter. Then to keep babies warm, nowadays use of polythene bag for babies less than 32 weeks gestation has been recommended. And in case you need a transport, you have to have pre-warm transport incubator. Then oxygen administration, as already said, that hyperoxia or reperfusion injury is more significant in preterm baby, and you should use oxygen judiciously. So you need to adjust oxygen according to your pulse oximeter readings. So you have to have pulse oximeters when you are managing your preterm baby. Then when we are considering assisted ventilation, then you need to be careful. You can start with CPAP if the baby is breathing spontaneously and has a heart rate of above 100, but is having difficulty such as labored respiration. Use of lowest possible inflation pressure should be used. Then consider giving surfactant if the baby is not. Then you have to have neuroprotective actions so that baby will be intact when baby goes home from your NICU. And these are the special precautions like monitor blood sugar, watch for apnea, bradycardia, monitor their hemodynamics, monitor their oxygenation and ventilation, and to start feeding as soon as possible. And nowadays, delivery room practices, you are having a neonatal transport, good neonatal transport is also equally important and should be taken care of. So these are the two photographs I have taken recently. So actually we need these kind of delivery rooms, but still there are places in Nagpur, three-story obstetric setups, but still they have a facility for babies like this. So the change, like we see that we think that PSCs are only having such kind of setup, but still in Nagpur we can see this kind of. Baby would be happy to see come to this kind of setup. So next target of our IIP and NNA branch would be Neocon 2023 because every newborn matters to us. Thank you. Thank you, Vamsi.
Thank you, Milind. I think what you have said, we are senior person.